must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hi, everyone, and thanks again for listening to another episode of the Healthcare Education Transformation Podcast. I'm your host, Stephanie Wyrock, along with F. Scott Fiel and Brandon Pullen, and we're joined today by Dr. Robert Sellin. Dr. Sellin is the chair of the American Board of Physical Therapy Specialists, or ABPTS, and has been very active in both the state and national physical therapy associations. He's the past president of the Kentucky Physical Therapy Association and the past president of the American Physical Therapy Association's Academy on Clinical Electrophysiology and Wound Management. He works in private practice in Lexington, Kentucky, in a practice that provides clinical electrophysiologic testing on EMG and NCV. So thank you so much, Robert, for joining us today.
Oh, Stephanie, my pleasure.
Tell our listeners a little bit about yourself and how you got to where you are today.
Well, it's interesting just talking to Scott before we started about East Carolina. That's where I went to physical therapy school. And really that was kind of happenstance because I had gone into the Coast Guard in 1970 and came out in 74 in a place called Elizabeth City, North Carolina, and had decided while I was doing volunteer work in hospitals that I wanted to be a physical therapist, and ended up going to East Carolina and graduating from there in 1978. Just really hard to say those numbers with a straight face. So, I was very fortunate at East Carolina. They had a lot of, they had a couple people, Dennis Davis and George Hamilton, that were very into electrophysiology, EMG nerve conduction, which turned out later to be something that I really liked and spent time with. But from there, I just couldn't see myself getting a regular job. So I joined the Navy as a physical therapist and then spent a career in the Navy as a PT, and was just extremely lucky because in the Navy, they encourage you to get involved in your national organizations or state organizations. And so that's what kind of spurred me to get involved initially with the section on clinical electrophysiology, and just happened to get mentored by some wonderful people. And the Navy sent me to graduate school at USC, and I got to work in the gate lab with Dr. Jacqueline Perry, and then do some, not much work with Dr. Hislop. She was not doing a lot there. We just had more conversations. But Dr. Joan Walker was my mentor. And so I really had a great luck in being with some really cool people that helped me along the way and got me involved in all of this, both physical therapy, but also physical therapy involvement in our national organization or wherever you wanted to fit in. And it turned out I fit in pretty good in the electrophysiology world.
How did you get in? So I know that you've been very involved nationally. I'm interested in how you got involved in the American Board of Physical Therapy Specialists.
Yeah, that is kind of interesting. Because especially, this kind of ties in with the history of specialization, really. This whole business started, back in the 70s. I can talk about that later. But even though I was in the Navy, I spent time with the Army and down at Fort Sam Houston. And my boss there was a guy by the name of Dave Greathouse. And he was one of the first members of APPTS that was one of the founding members, in fact, that helped put the exams together from the very beginning. And And I saw him, and then I saw other people that I knew that were getting into specialization. So one thing just sort of led to another. And then when I was working with this section, I got volunteered to do some work with the ABPTS many years ago, and it just got my interest. And once you become, and so we'll talk later about this, that as soon as I became a specialist, which was early on, I was in that group in '89, somebody came right up to me and wanted me to get involved with the examination process, because we like to always involve both seasoned veterans and brand newly certified people in the process from the beginning, so that you get new ideas and old ideas and all that kind of stuff. And that's how I got into it.
I think that's really interesting, especially knowing that how you had kind of met one of the early founders, creators of this, and how it kind of built up from there. But, I'm curious here, Bob, because I recognize that there might be some people listening that perhaps aren't aware of kind of that history a little bit. So if we could, do you think we could dive a little bit deeper into the history of ABPTS and kind of how it's developed and transformed where it is today?
It's really interesting. So every specialty area, everything that has to do with specialization, or like any other major thing within physical therapy, starts with something with the House of Delegates. This started back in 1976, that the House of Delegates commissioned a group to kind of look into the whole concept of specialization. And from that group, that a task force was developed. You hear these things, and if you're a clinician like me, you start hearing these words like task force, and it makes your eyes kind of roll back, and you're thinking of meetings. And these guys men and women got together, and they developed this idea for clinical specialization. And it just takes time. So that started in '76. They had the precursor of ABPTS, was a different group with a different name that came together in '78, and then ABPTS was actually formed in '79. And that was a group of clinicians, this Dr. Greathouse, Dave Greathouse, who was my boss, who then couldn't get specialized for many years because he helped develop the first program. So he had to be away from it for a number of years before he could come back and take an exam that he would be completely different from the one that he originated. And it was a real sacrifice from people like that to do these things. So they got that together, and then each specialty area, it first started with cardiopulmonary, which first applied to become a specialty area back in, it was in '81, and then clinical electro was in '82. They send in their application to this new group that had just started, American Board of Physical Therapy Specialties. And there's a big process, which was still just really in its infancy, of how do you prove your specialty? Why do we think this is a unique part of practice within physical therapy? And they proved that, the first two again. And that, again, they were approved. They went through a process from 78 to 81, 78 to 82, just to get the application. Once the application was done, it took to 85 for cardiopulmonary to get their first exam together. And that process is still going on today in new specialty areas as they come on board. Am I with you? I don't want to get too rambly. I get going on this, but that's how it all started. And then it has grown now to where we have 9 specialty areas, with the latest one just coming on. Well, oncology just got approved. And so the way this worked from the beginning, for example, oncology sent in their applications back, I think they started probably in 2012, maybe 2011. And the whole process took them to 2016 to get approval from ABPTS. And then the next step is to go to the House of Delegates and say, okay, these people have done everything. Will you approve them as a new specialty area? And then from there, then they have to do the work, and we'll talk about that later, to put together an exam and all that kind of stuff. And they're actually giving their first exam this year in 2019, which is really amazing, because on average, it takes 4 years to go from, yes, you've got it all together, go do it, and then being able to produce an exam in a specialty area. And that's sort of how that works. And wound management is the latest specialty area to they had their application took probably 5 years to finally get approved. And that's hard years of a lot of volunteers doing a lot of work. There was a hearing at CSM, just in DC, where people gave testimony for or against, and it was all for. And I will have the pleasure of sitting in the House of Delegates in June when we present this to the House of Delegates and ask the House of Delegates to approve a new specialty area in wound management, because they have to approve it. And it's the House of Delegates. So, I mean, we've never brought one to that level and not have it approved, but that's the process.
And quite a process, it sounds like, Bob.
Oh, my goodness. Yes, it's changed now. The process for application for a new specialty area is constantly improving and evolving. It's evolving. We hope it's improving. Yeah. It used to be just one big, unbelievable amount of work to do. It's still an unbelievable amount of work to do, but now we've divided it into 2 phases. And phase 1 is that you have to go out and the first thing that you have to do is you have to do description of specialty practice, and you do that by doing a survey of all the people that potentially might be or might not be specialists in the area, and you have a practice analysis. You have to do the practice analysis first and get that approved, and then moved on to step 2. And anyway, so that's sort of the process right now. And the practice analysis is a huge deal because on average it takes 3 hours to fill it out. So you have to find people that will sit down and fill out a 3-hour survey. They have to be somewhat, I made that time up. It could be 2.5. But I've done it a number of times for clinical electro. We have to do it every 10 years. Anyway, I'm sorry, I drifted off there, but that's sort of that's how we started. And now that we have specialty areas in the 2 I mentioned, plus geriatric, neurologic, oncology, orthopedics. Orthopedics by far the biggest specialty area, where they have thousands, or some of us have hundreds. Pediatric sports, and of course women's health as well.
For sure. Well, Bob, this has been kind of a hot topic in our field lately. And, with rising student debt loans, decreasing PT reimbursement, and even inconsistent employer support for board certification, why should someone pursue a board certification given some of these constraints? And what does the ideal candidate maybe look like in your eyes?
Well, that's interesting. There's 2 ways to pursue board certification. Now, there used to be just one. It's the one I prefer because it's the one I did, which is you get into it because you have a passion for that field. And you want to be able to be associated with people that are really good at what you want to hopefully someday be pretty good at yourself. And so the driving force is simply trying to be good at what you do, and better than average, to say the least. And I think that's always going to be there no matter what the financial implications are. But then now we have residencies and fellowships. Now, residencies are very specific for clinical specialization. And over the past few years, especially the last year and a half, ABPTS has started to work much more closely with the Association of Residencies and Fellowships, so that that clinical practice survey that you have to do to set up a residency is exactly the same as you would do to get a specialty area. So if you do one for one, you've got it for the other. So the residencies can tie in more to specialization, but that's a cost right there. So I mean, that I would have loved to have gone to. I wish that would have been available when I was able to do it, but I also was just married with children, and I don't know if I could have done a residency unless it had some kind of way for me to earn money while I was doing it, or the Navy paid me, which I was fortunate that they did a lot of that kind of stuff, if people don't have that. So there's always got to be, in my opinion, an option that doesn't involve a residency, so people that can't afford those and can't go to them can do clinical practice and still work their way to specialization. Although personally, I can see that there is a definite movement in the world that seems to think that residencies are the way to go, and I wouldn't be surprised if it gets pushed more and more, and that's fine too. It's certainly an option, but I just don't see how people can afford all these options. So I think the answer to that is you get into specialization because you want to be good, and you want to be around people that are good, and try to do it in a way that you can afford it the most. But it's only about clinical excellence.
The mission, Bob, of the ABPTS is to advance the profession of physical therapy by establishing, maintaining, and promoting standards of excellence for clinical specialization and by recognizing the advanced knowledge, skills, and experience by a physical therapist practitioner through specialist credentialing. So I know you had just talked about, that potentially residency is not for everyone, but it's something that should be an option. How do stakeholders like board members, the delegates for House of Delegates, board of directors, committees, task forces, and the staff of ABPTS work together to achieve this mission?
Well, that's a lot of people there. And first, the staff is, if you ever work on any of these boards, the interesting thing that I really like, I always worked in small section, clinical electro. If you're in a small section working and you have a job, whether you're the publications chair or the president, basically you're kind of doing everything, and you have limited support staff because that's not why people are spending their money. They don't want to spend money to get support staff. People are expecting volunteers to do the work. The good thing about when you get in with ABPTS, you actually have professional staff members that help coordinate the things that you do so that you can spend a lot of your time really on the quality of the product and not just figuring out how to get the letter out. And staff does a really good job of putting us together. Now, for instance, we have an ex officio member from ABPTS that's on the Education Leadership Partnership. That's me right now, but it'll rotate every year. That Educational Leadership Partnership puts us in contact with CAPTE, APTA, ACAPT. Everybody is at that table in one form or another. So we're getting to hear the conversation between everyone. We are definitely getting much closer in working with, again, the residency and fellowship people, because we have such a link together as relates to specialization. Don't do as much directly with CAPTE, and I saw that on there. And the relationship between the state boards, really probably the only relationship I think of is that we all work very hard on how to produce items for high stakes examinations. So we have a board of director member on ABPTS who is a liaison with us. But basically, I think it's the groups we work closest with are residencies and fellowships, and now much more with the education leadership side. I don't know if that answers that question exactly, but
yeah, for sure. And I think you kind of hit on a couple of interesting points there too, Bob. But what are some of the legal factors as far as like state or national laws that influence how standards and testing are handled at ABPTS?
Yeah, I saw. That I don't know that we've. As far as standards and legal factors, first the standards that we set up through the exam that I back off on. The board, the specialty examinations have from their beginning gone through a professional examination national company. And over the last 10 years, that contract has been with the National Board of Medical Examiners, and maybe 12 years, I can't remember exactly. And we're up again. And that relationship has been fantastic. Now, the National Board of Medical Examiners, they're the same people that issue the MCAT exam and other specialty exams for other medical professions. And it's a group of professional psychometricians and their assorted staff that know how to professionally put an exam together. There are really I know of no state or national laws that directly influence the production of this exam, if that's what you're looking at. I mean, the exam is given in test centers across the country. And as far as I know, the standards, when I think of standard setting, the standards come from the professional guidance to our psychometricians and our clinical experts that are writing the exam. But there's been no real specific legal things that I can think of, unless I'm missing the point there.
No, I think that you make a really good point, and I think that that's something that is really interesting to think about. Explain how these specialty exams are developed to our listeners. What is the criteria for the selection of the subject matter experts that you choose, and then how do you word a question, or how do you structure those questions?
I know that depending on when or if you ever take one of these exams, everybody has some different opinions on them, but tends to be that one question you remember in your mind that, I can't believe they asked that. Unbelievable amount of work goes into making an exam. That's how I started with the whole process. And that came about, and the reason I'm saying this is because I think it'll help me tell you how these exams are put together. I had recently just become board certified. I was very surprised to be asked to go to a meeting in Philadelphia, and that was not with the second meeting. So we'll go with National Board of Medical Examiners to go to their headquarters in Philadelphia with a group of other clinical electro specialists and sit in a room, and we're going to work on putting an exam together. Now, where that exam comes from starts with items have to be written, obviously. So items being the test questions. And those items come from a group of writers that we call the SACE writers, the Academy of Content Experts. And you become one of those simply by being certified in the specialty area that you're going to write the test question for, and applying to ABPTS or to the ABPTS office and say you want to be a SACE member for orthopedics or this or that. And you send a resume and an application and show your level of expertise in your specialty area. And if you're in a small section like clinical electrophysiology, if you meet all the criteria and you're willing to write items, you sort of get into the fold of being taught how to write items. In other areas where they have hundreds of people interested, then the selection process comes down to the specialty council, which is the group of people who put the exam together. Each specialty area, orthopedics, oncology, whatever, have 5 specialty council members, 4 or 5, depending on the specialty. And those council members, one of their jobs is to put together the examination, to go through the application process, to make sure people apply correctly and do all of those things. So one thing they have to do is go out and recruit or select people that will then be trained by the National Board of Medical Examiners on how to write an item. And I've done a lot of teaching, but I spent most of my time as a clinician taking the courses on how to write a good test item were eye-opening and have helped me very much in my teaching endeavors, at least in trying to put a fair examination together. And so the item, if you become a SACE member, so to become a SACE member, you apply and then you get sent. You don't get paid for it, but ABPTS pays you to go to CSM. No, they don't pay you to go to CSM. They buy you lunch at CSM. That's it. You pay yourself to get there. And they have a day-long class put on by professional test writing psychometricians that is outstanding. You've already taken an online course on how to write an item, then you get an in-person course, and then you write items there. And then in the afternoon, you meet up with people that are in SACE too. Those are folks who have come back a second time to write higher level items and have further instruction. So it's a process of teaching people how to write these items. Every item that you'll see on any of the specialty exams is going to give you, in general, 4 possible answers to a question. Most of these questions are going to be high-level questions, usually involving a case study or some kind of analytics, as opposed to what's the nerve that goes to the brachioradialis muscle. You're not going to have those kind of questions. You're going to have what happens if Johnny gets shot in the brachial plexus and this doesn't work. So there are going to be higher level questions that have to do with analysis and usually case studies, but the answers are almost always going to be 4 selections, A, B, C, and D, because they found over time that is the best number to have. You'll never see a true false. You'll never see a take in these exams, take A and B, C and D, L, and it's going to be one of 4, 25%. And when you write an item, you have to give references not only for the correct response, but the 3 distractors. And the item can't be a giveaway in the way it's written. So they teach you all these kind of things about how to write items and how to set them up. And that's basically where the exam items come from. And they go into a bank of items. And you just can't write randomly. Everybody might want to write is an expert on one thing. Unfortunately, what we have to do is once you have set up your specialty area, you have set up a document called the Description of Specialty Practice, which is a basic book, a little pamphlet that explains everything you've done, all these months and years of work to put your practice together, that says our specialty practice is 5% this, 3% this, 15% this, whatever it happens to be. And you look at that book, and when you get an exam, 3% of the questions are going to come from that area, whatever we've set up in this description of specialty practice. So every item you've written is now going to be coded in about 3 different ways. So it goes into a big secure bank that when we go to put an exam together, we have a pile of items for each little thing, the hand, the elbow, the shoulder, to make it simple. Are we okay so far on that, on how this exam goes together? Because it's not real simple, but you know.
Oh, yeah.
No, you're doing good. Bob, can I ask you one follow-up to the questions? Because when we talked with FSBPT, one of their criteria is, of course, using the most common textbooks to cite the correct answer, but also being able to cite why the other answers are wrong. Is that similar for these exams as well?
Yeah, that is correct. I mean, yes, and the tricky part, you're exactly right, because you want to be current, but you don't want to be so current that you're asking them a question on the article that you read in Muscle and Nerve yesterday that maybe everybody doesn't have. And it's not the standard of practice. So we do use textbook. We also use reference journal articles that tend to be standards of the practice. Now that's arbitrary, you know, at best, at some point. But there's a balance in there. But exactly right. That's what you're trying to do. When you're putting this stuff together, is think of those things. But if you use textbooks, you're dealing with 10-year-old material. But in a lot of our areas, that doesn't matter that much. But in some areas, it matters a whole lot, especially if you're dealing with sports and orthopedics and concussions, and you're doing it 5 years ago. Well, you know, so there's a balancing act that goes on all the time in these areas. And then you have to be able to inform your audience what to expect when they come into the exam as best you can.
For sure. It definitely sounds like there's kind of a dance between balancing all those little avenues there. And I'm going to go back, Bob, can I ask you one follow-up on the subject matter experts? Because you had mentioned about some of the qualifying criteria and kind of the path that they have to go through. Are there any other specific qualifications that they have to have apart from what you've said regarding research or service? Like, are there any other things that kind of influence or things that you're looking for in a subject matter expert?
In the ideal world, yes. I mean, you want, because we all have different expertise, and we're always struggling for the person to, because every test is going to have, across specialty areas, let's say questions on ethics that are rather difficult to write a question that is challenging and fair and not obvious, but you know, those kind of things, and or the stats guy or the research guy or lady, and you want those people that have those abilities, and you do try to balance that out. In the smaller groups, a lot of times you're dealing with people. You know, somebody's got to step up to the plate and do these things. I'm just being honest with you, but that's why in the exam, when you put the exam together, you have checks and balances on the exam itself, so that the item is graded. And almost a little more about the exam. Generally, it's a 200 question exam. Not generally, it is. Usually you will find that you get 225 questions on this exam. 25 of those questions are not going to be graded. They're items that have never been used before, and we're going to get a history on them, on how well people answer them, and are they good questions or valid questions based on psychometric look at. Anyway, so we try to do different methods to get the questions fair.
No, that makes sense. And Bob, from your perspective, because you had kind of just mentioned that with the subject matter experts, and you had kind of basically said it's, you know, and forgive me if I'm misquoting here, but trying to get people to step up to the plate. Is that probably more the biggest thing that you see that's maybe an issue in that department, like just having people step up and do that, or is it something else?
No, it's hard to do. Writing items is hard, and you get continuing education credits for them. But for the work you do, we try to get every item writer to produce 10 items. And again, we have a senior item writer who reviews all the items. And before they ever get reviewed by the whole group, we have experienced writers that look at every question before it even gets really analyzed by the psychometricians and other people. And it's a teaching thing. We want to bring people in and teach them to write these. We need a cross section of people to do this. And if you're in my field in clinical electro, and we got the three guys that are great in statistics. We hit them up all the time. And, sometimes you have to get other people to do it. In a bigger section or in a bigger group, it's sometimes easier. But I'll tell you what, it is. I don't know how honest I'm supposed to be, but it's a challenge. And this is a volunteer organization. You got to get people to do them. Fortunately, we've got great people in all of these. If you look at what oncology has done they've put together an exam in 3 years times 3. So they've got 600. So they've done great.
Yeah, that's awesome, Bob. And, there's been a significant discussion in PT about whether residencies and specialization should be the normal continuum after completion of PT school. I'm just curious where you sit on this debate, which side you tend to fall on.
I was afraid you might ask something like that. I love residencies and fellowships. I think they're fantastic. And when I was lucky enough for the Navy to send me to graduate school, I thought I was going to be able to go to the orthopedic Kaiser fellowship residency, whatever it was called at that time. But there was kind of a contest between whoever was running that and Dr. Hislop. And anyways, that didn't happen. So, gosh, if I had the opportunity to do a residency in early stages of my career and there was some way to do it and pay for my family and all that stuff, I'd love to do it. Right now, I don't think especially with how many years you're already going to school, I'm amazed at how many people actually do this because of the cost. But you have to have it's got to be quality. You have to come out of it with increased clinical knowledge, but I still think you need opportunities to advance your clinical skills without going to a paid-for residency. So I'm of the old school on the other side. I fear a little bit that someday it's going to come to where somebody finally says, by gosh, it's mandatory. We can't be having people becoming specialized if they don't go to a doggone residency. Well, I'm pushing Social Security age, so it's not going to be my issue, but it won't. I don't think my opinion will change. I think you need an opportunity to go without a residency. And 20 years from now, somebody will look back and say, can you believe these old guys used to think you could do this without going to a residency? I have no idea, but I've seen the world evolve in ways I never thought possible. So who knows?
Do you think, Bob, that if we were to make residency kind of something that is the norm in PT practice, do you think that this would risk early specialization, and would that be good or bad? Or do you think that we should also maybe develop like a general track type specialty, like a general practice specialty?
Well, those are two separate items. The first one is, I don't think there's a yes or no answer to that. For some people, they know what they want and they want to get into it, and that's fine. I know I had a person call me from PG school as he was graduating from Creighton 20 years ago, saying all he wanted to do was tell me how to become an electromyographer. That's what I want to do. And he's now one of the best ones in the country. And I just thought, who is this crazy guy that wants to do EMGs right out of school and not even thought we had to go work in a hospital first and do all the things that I did. But everybody's different. And the data so far that we've seen on people that go through residencies, they certainly do well on the exams. They do as well or better than people that have put in 5 or 6 years and taken it. Right? We don't have enough data to be really solid about that. There's no big differential in their score performance on examination. Does that translate to clinical practice? I'm not sure. But the whole idea of a generalist as a specialty area, that's going to be an interesting topic that's coming forward in the next year or so.
Yeah, Bob, I've been practicing 12 years and I still don't know what I want to do. So,
yeah, I'm with you. No, Scott, I understand. No, I do. I mean, I've been really fortunate that all I do in my practice is EMG and nerve conduction. I have done nothing else for the last 15 years. But for the first 20 years, I was all over the world, working in Romania after the revolution, in Africa, doing everything a physical therapist does. And I loved all of that to a certain point. But I realized what I really love is what I do now. But gosh, but so what's the right path for any person? I don't know. I just can't see. I don't see how somebody can commit to all these years of education to be a physical therapist. I think when they start looking, I mean, you got to look at the cost basis, the risk reward. There's a lot of factors to be weighed in there. I don't know that I would have made the same decision when I came out of the service the first time and had just gotten married and was looking for a career in healthcare. I'm not sure I would have selected physical therapy if I thought it was going to be 7 years at that time.
Well, yeah, and to add on to that, you're mentioning, of course, the data with specialties and such, and of course, looking at residency fellowship education, again, that's in its infancy right now, and we don't really have a lot of evidence. I mean, there's the Rodriguero et al. Study where they looked at outpatient outcomes for, residency trained, fellowship trained, and, while the results of that did show that, yes, residency didn't show a really significant difference, fellowship did, we also recognize that there's still some issues with that study that we can't make a broad generalization with. But, then I also get the other side of it too. Like I get how, we want to try to elevate the profession. I'm all for that. But I also understand the point that if we go into a specialization so early that sometimes we kind of stay in that lane. And if something else shows up that we may not be the best prepared for, does that make sense?
Oh, absolutely. I mean, yeah, I'm so thankful that I was so lucky in my early career to see so many things. And a lot of the things I saw, I never wanted to see again, but they change. I mean, even today, I just have to tell you, today was not an easy day for me. Today is one of those days as an electromyographer that happens to me about once a year when someone comes into your clinic with a diagnosis of some kind of peripheral nerve problem, and in 5 minutes they have ALS and they don't know it. And and you got to test them and do all this different stuff and go back to the surgeon and say, yeah, I don't think you need to release their ulnar nerve at the elbow. This person has ALS. So, but I think it's the experience I had through all my other time that helps me go through those. But our profession is so fantastic. I mean, even as that is just the interaction with people and to be able to do what we do. I mean, it's just fantastic. I'm sorry, that's been on my mind all day today since about noon. And it's just something, it doesn't happen that often, but you can't shake it off. That it's still, whether you're treating people or analyzing their problem, we just have such a unique ability to talk and be with people. And I got sorry, don't mean to get on the PT soapbox there, but anyways. But I think I think people should have some experience before they go into these other things, but I certainly wouldn't stop them or try to stop anyone from picking a specialty and going for it after school. It might just be the way they want to go.
There's also been some discussion in PT about implementing a practical examination portion with specialization. What are your opinions on this?
That has been talked about since the beginning of time. I think it was the Egyptians wanted to do that, but I'm not sure. Practical exam, I'm sorry, this has been, it's, everybody knows that one of the best ways to test somebody's skill level when you're working with them in the clinic one-on-one is to see if they have hands, if they can do the job, if they can stay cool. There is, at least with today's technology and the cost, to do an objective hands-on practical exam, there's just no practical way to do it. I go back, I got certified, I got a license in California when I was stationed out there, and then they had a practical then. You had to take a practical to get your PT license in California. And that got thrown out in court eventually, I think. I mean, it's just really hard to do that objectively. Plus, the time and cost is so prohibitive. You might be able to do it in clinical electro where we have 30 people apply. But when you have 2,500 people apply in orthopedics and you're going to do a one-on-one clinical practical exam with them, now maybe there'll be a way to do it technologically, but our exam process now, we're getting much more video and real-life scenarios, so you have to think through problem solving. Even though your hands aren't on a patient, you have to use the same skill set as we get more sophisticated in our examinations, that for analysis and patient scenarios and away from just simply answering a question. So I think that's the only way right now we can do it. I don't know if in the future there'll be some other way to do that with electronically. I just don't know. But right now, we've looked at it 100 different times, especially dealing with manual therapy and things like that. And the numbers, at least for how we're set up, there's just no practical way to do it.
Yeah, Bob, what would you say are some of the strengths and limitations of specialty examinations at current time?
Well, I think the strength is and again, it's interesting when you go into when you're going for the first time to put these exams together, they use a term constantly that at first is kind of demeaning and crazy, but it's called, when you're looking at an item on an exam that you're going to give to a person, you have to think of it in terms of what would a minimally competent clinical specialist do on this test? So by having specialization, you're at least trying to raise the standard to a certain level. But you're not making everybody that's a specialist is not necessarily the greatest expert in the world, especially when they have achieved a new level. They have proven that they have a base level of knowledge that is above what they should have gotten just from PT school and from regular practice. They've worked hard and they've shown a higher level. So I think that's good. But do we have a way to show, to sort out the really great clinician from the good clinician and things like that? Well, we don't have a test for that. And there was another part to that question, Scott. I forgot what it was. I'm sorry. But
just playing devil's advocate, the weaknesses of the exams.
Oh, yeah. I mean, well, because it's an exam, and we try to follow that specialty, that DSP and things. And we may not hit all there may be flaws in that, but we work really hard. So I think the biggest thing, it's just because it is an examination, and you'll see somebody come up and say, I know I'm a great clinician. I could do all those things, but when you ask me that question, man, I just can't answer. And there's probably truth to that. Some people just don't do well on exams, but they can be the greatest clinician in the world. We can't factor that away. So anytime it's an exam, you're going to have that kind of problem. We just try, and when I say we, I mean the whole system works really hard to bring the exam as fair as possible to everyone that's going to take it.
How often do the specialty exams get updated?
Well, there's a different process for different specialties based on how many people take them, but the exams themselves are altered every year, and there's two forms of most exams, and usually about every 2 years the exam is almost completely changed. When I say completely changed, the item banks get shifted around. These items are all categorized by in different areas, and when we go in to put an exam together, we usually use that same form of the exam in one shape or the other for 2 years. But in the bigger areas, there's 4 exams that might be altered every 2 years. It depends on the size and the number of people taking them.
I know that you had said earlier that the exam is tried to be updated to the most recent evidence. How do you guys do that? Obviously you said that something that was published yesterday is not necessarily going to be on the exam, but how do you decide what's integrated into the exam and what maybe you leave out?
Okay, so that process, that's an excellent question. When you get together to put this exam together, you get a group of 4 or 5 people from your specialty area to go to the National Board of Medical Examiners in Philadelphia. The psychometricians there have already put together an exam template to start with, because you have this item bank that you've already made as a group, not you individuals coming there, but your SACE writers and everyone else, that has all these different items that have already been approved. Many of them have already been on different exams and have been, every time an item is used on an exam, it's graded on how many people got it right, how many high performers got it right, how many high performers got it wrong, how many low performers got it, all these stats on every single question. And so you come into an exam room and all of you sit down and you have, you literally take the exam that they have put together generically based on your description of specialty practice, and your item bank, and you sit there and you take that test yourself individually. And as you answer each question, you answer some questions on the side on statistics, like how likely would a minimally competent specialist get this right? How unlikely is that? And some other questions. And at the same time, you're all reading these exams in these items, and somebody's going to go, what the heck? That item, I just read about that yesterday. Why do we have that on this test? So they're individually being reviewed by 4 or 5 people, each item, and there's a grading system that you do, and then you're graded. So you also take the test. You don't know the answer. So you said, oh, this is simple. Everybody should get that right. And by and large, boom, boom, you got it wrong. So maybe you didn't read that question exactly the way you thought you did. And so that's how it's done. It's just manual work, looking at each question individually, and then trying to decide the degree of difficulty of each question. And is this a relevant question? Is this question something that this group of people says, you know what, I think we should all know that. I mean, it's a group of experts making that decision. It's not one person. A group of experts has a wide range. Again, and every time you put an exam together, you usually have at least one person who has just been board certified within the last couple of years, and then people with lots of experience putting exams together, people with lots of experience but no experience putting an exam together, kind of mix them together, let them look at all these questions and kind of fight it out as to which ones are good or bad as they put that exam together. It takes 2 days of about 20 hours of work to put one exam together and that's with all the items already pre-written and put in place.
So Bob, one follow-up to that. So say a clinician's listening right now and they're maybe not necessarily going through a residency program of the such, and they're wanting to prep for any kind of specialty exam. I know this is going to be kind of varied, but I've heard some things from different people. Like I've heard you shouldn't read research that's like recently, like 2 or 3 years or something like that. What's your kind of golden rule for that regarding the exam? Like what would and I know it's going to be variable based on a lot of factors, but what would your best guess be?
I know my field real well, and there's a couple of, in clinical electrophysiology, it hasn't changed a whole lot in a long time. So it's a little bit more static. So there are some standard text over diseases and things like that everybody should know. But I think part of that is still true for every profession. I think there are classic ideas in orthopedic evaluation and treatment that are pretty standard. And so you need to know whatever that Bible is that you go by. And I have to be really careful there, because one thing we never do, especially from ABPTS or from any of the councils, we can't say, go read this book, but you look at the description of specialty practice, and if it says 2% of this exam is going to be on the fungus that grows on your toenail, I would not spend a lot of time studying the fungus on the toenail. But if 20% of the exam is on the temporomandibular joint, you might want to spend a lot of time there on whatever. You should know the mechanics. You should know all the, and you're right. You don't probably need, the test is never going to reflect the article that came out in the last year, unless it's just not going to, no matter how dynamic that article might be.
Right. And kind of switching gears a little bit here, Bob, because I know this is an issue. Being a clinician and being out there a little bit is recognizing that not every employer really values board certification the same way. So how would you recommend, I know you had kind of mentioned part of this a little bit earlier on in the episode, but how would you kind of sell the value of board certification to an employer? Like, say if I wanted to go for an OCS, but my employer maybe doesn't see the value in wanting to sponsor or contribute to that. How would you help? What would you recommend to help that clinician perhaps have the best encounter with their employer to see that value?
I would definitely use that if I was applying for a job to show my expertise. One thing you could do is say, you could look at the percentage of people that have this specialization within physical therapy. We have a total right now of about 24,790 or something people are clinically specialized in physical therapy in some way. And that's still a rather elite group. If you think we have 100,000 members, give or take, in APTA, and I don't know how many PTs are out there, but it must be, I don't know, a whole lot more than in our association, that's for darn sure. So you're in an elite group that has proven a higher level of competency. I would do it that way. If they're not interested in that, then maybe they're not that interested in having clinical experts work in their department, and that's not the place for you. But I would emphasize, because of your clinical expertise, that you can show with that. I've just seen it the other way around. I've been in clinical electro. It's something we have to have to deal with certain insurance companies.
For sure, Bob. What is your utopian vision? And are there any changes that you'd like to see with specialty certification upcoming?
I would be very surprised if there aren't some big changes on the horizon, just based on the numbers of groups that send inquiries into wanting to develop some sort of specialization. It's really hard because a lot of folks just don't understand how big the process is, and how exacting it has to be to meet certain standards for this certification. Different than just a credential. This board certification has to meet a lot of standards. In fact, right now we're working with a group that actually standardizes and is going to accredit us as a board. But there are very dedicated professionals who want to set up specializations that right now don't maybe meet exactly the definition of what we have in our policy and procedures manual, but we may have to relook at how we define a specialty. Because right now, if a fellowship let's say in neonatal intensive care, that wouldn't lead you to a specialty, but there are people in neonatal intensive care that think they should get this credential that we have. Is that going to be a possibility in the future? I don't know. And that's just one of 20 of inquiries that we've had of very dedicated professionals looking for this credential. And I don't know where it's going to evolve right now. It's under discussion and litigation.
How has APTBS been educating the general public on specialization in physical therapy?
We put out, you're talking about ABPTS and ability to publicize and let people know about specialty areas, and we do. There are a variety of different pamphlets and discussion, but I think it's a tough one. It's really confusing in the whole medical world on what people are. And I know from the other questions I've seen written down here, there are so many different credentials out there. And then we just had the recent House ruling on what's the proper way to show your credentials. And I can understand where they're coming from. They want you to not have everybody having this alphabet soup after their name. So they don't like us to use like ECS, Electrophysiologic Clinical Specialist, but you can write it out under your name. I don't know if that helps us or hurts us as far as letting people know what specialists are. So there is a whole department that tries to work on that. I'm not that involved with it, and I don't know enough about it to speak too well on that.
Yeah, so I know that in the profession, a lot of physical therapists and people who are our patients talk about how, patients don't know what these letters mean. Do you think it's important for clinicians then, if APTBS or APTA aren't educating the general public on what these mean, is this something clinicians should do, or is this something that we shouldn't even really worry about because it might not even matter? What are your thoughts on that?
Yeah, that's a really good one. Yeah, because depending on where I'm working, I might have a lab coat that they put together for me that has different credentials on it and things like that. I've always found it just my job to explain to them that they've got to learn who I am. Usually when you're a physical therapist who's an electromyographer in a town where the other 1,000 electromyographers are neurologists and physiatrists, and it's a little bit of a hard sell from the beginning. Why would they trust a physical therapist to do something they've always sent this to a neurologist to do? So that's where being a PT really helps, because you can get their respect as a PT and then show them what you can do in your specialty area. And I think it's the same thing if you're cardiopulmonary or if you're an oncology specialist. You show them with your expertise, and then that explains their credential.
Yeah, no, Bob, I completely agree, because I recognize, but just hearing from what you've talked about tonight about how much is really involved in the time that's needed to do what you guys have to do. And plus, recognizing that patients may not necessarily go to that website and look into it. So I agree with you. I do think that it should naturally, I think the clinician's probably going to have more of an effective effect on that than maybe ABPTS.
I mean, how much stuff do you read? If I got something in the mail that told me that, I don't know. Yeah, it's actually a really good question, but I'm trying to think about what I really know about my nurse practitioner that just got her doctoral degree and now she's doctor nurse. There's just so much of that going on in all our professions right now. I think it's a great question, and it's I don't know that we have an easy answer for it.
No, I can totally see that. Well, Bob, I want to finish up tonight with kind of our big cheese, our big finale question, as you will, because of course our podcast is called the Healthcare Education Transformation Podcast. So of course, with that being said, we got to ask you this. If you could change one aspect of healthcare education, now whether that be DPT or other healthcare provider related, which aspect would you change and how would you change it?
I think that I have learned the most throughout my life in one-on-one relationships with clinicians, trying to figure out how to sort out the 9,000 things you learn in a schoolroom setting to the 2 things you should have seen as soon as you walked in the room when the patient came in the door, and how to make that practical transition. And this is where I get kind of confused with my own self, because where do you do that? Well, you do it in a residency and a fellowship, but why can't we figure out a way to do that whole thing in less time? How much didactic do we really need before we do hands-on work? I don't know the answer to that. I wish I could. I just know that, and it was horrible. My first volunteer work back in 1970 something or other early, I went into a clinic, knocked on a door. I don't even want to begin to tell you within 3 weeks the stuff this guy had me doing in this little hospital in Elizabeth City, North Carolina, because I'm pretty sure we can't let PTAs do it today. And I'm not saying that's good. I had no idea, but man, I learned a lot of stuff working with him hands-on. I couldn't read a journal. He gave me these journals to read. I couldn't read them. I didn't understand, the language. We got to figure out a way to, and I know people are doing this all the time, and I'm not a real educator. I spend my time in the clinics to spend more time getting people involved with people and less completely didactic. And I know it's all happening with clinics in places, but that's my 2 cents worth. And I don't think we need more years of school. I just don't understand all those, the cost benefit relationship to all those years and what you come out with. I don't see that. I go into clinics every day and I'm like a fly on the wall because I go in a little room and do my thing. And I'm watching people practice today, and I am not seeing the evolution of change that I expected to see with all these extra years of education. I still see some of the same equipment. I still see them doing the same things. I don't know what's going to change that, but more years has not done it, in my opinion. I think you just still need and this is what good fellowships and residencies do. If you have a good mentor that brings you along and you see people and you know how to treat them. But by golly, I don't know. I wish I had a better answer. I just don't. It just still surprises me because again, I'm like the invisible man in half the places I go to. So I just look out the curtain or look out the door and I just see how people are taken care of. In some places it's fantastic. In some places it's not. And that's bothersome to me, but I don't know the answer to that one.
And you wonder, because I know a lot of people in the past have kind of mentioned, and John Childs has even said that our clinical education is what he would kind of call the black eye of, our profession, with the variance in practice, which therefore the variance in education, Because I recognize too, and I think a lot of guests have said this too, that, you know, didactically in an academic setting, they can only do so much to, you know, to get the baseline knowledge and get students prepared for those clinical education experiences. But then it's the clinicals where some of that like integration and kind of that avenue comes alive. So, and I know that's a huge topic, and I'm not trying to go down a huge rabbit hole here, but it seems like when we're having this discussion, it usually comes down to some similar things.
Yeah, and you know, and I know the things they do in Pittsburgh and other places where you know you combine your internship and residencies or whatever you want to call it with actually getting paid, and you know we've got to think about things like that. And you know how are we? I just don't understand in the smart human population. I cannot see how we can keep increasing the number of PT schools and PTA schools and the number of clinicians and think that the bubble isn't going to burst at some point. I mean, it won't burst for the schools. They'll move on to something else when that PT program doesn't get it. They'll find something else. The person who's going to be hurt is going to be like the pyramid scheme. Those last group of people that paid all their money to go to PT school and find out there's no jobs. I just worry about that for the future.
No, I do as well. And I think that's ironic because the number one most common answer we get is cost. The cost of education and, you know, the financial aspect of it. That's by far the most common. Yeah, I mean,
just all those things on the number of schools, law schools that are closing, and, you know, people are finding out that you know, you spend $110,000 to become an attorney, but you're lucky to get a job for $65,000, and unless you're going to work for that big law firm. We actually probably do a little better than that in PT for maybe the similar amounts of money, but at some point the market will decide it, and that's for sure.
Well, this has been quite a wonderful conversation, and I'm sure a lot of people are going to have some questions once they listen to this podcast. And if they do have any questions, where can people reach out to you? On social media or via email?
Yeah, email be good. You couldn't find me on social media, but although I did get on Facebook once and it made my kids so mad I never did it again. So, but yeah, my email address is bobsellin54. That's SELLIN 54@gmail.com. That's the best way to get a hold of me. I rarely answer my phone and not that great at listening to voicemail, but I'm just an old guy, you know, but email is always the best, but they can also call me if they want to.
I love your transparency with this. I absolutely love it, Bob. And would you recommend the ABPTS website as well if they want to do that too?
Yeah, it is good. And the people at ABPTS are amazingly wonderful people. When you think of the numbers, I looked at this just before this. I was just glancing at what the numbers. So when specialization started back in '86, so for like the first 5 years, there was like 131 people became clinical specialists. Okay. In the next decade, 2,600 became clinical specialists, which was like a growth of 20%, but it really didn't count because it was just getting started. The next decade, it grew by 2.5 times to 6,000 something. The next decade, which only has 9 years in it because we haven't got to last year, it grew again by another 2 times to 15,000, 16,000. So this is a process that's actually doubled every decade plus. That staff, even with all those numbers, you call them, they'll answer you, and they're just super people working there.
I love it, Bob. And I hate to say this, but I thought of one follow-up, if it's okay, since you kind of brought that up. Do you think that, obviously seeing that the growth and what it has, is it still continuing to increase from board certified? And do you see that changing given the financial constraints that we were talking about earlier?
Yeah, you know, that's really interesting because as I looked at these numbers earlier today, when I was just looking at obviously you can't keep that exponential growth going because you can't, in my mind, because you know we're already at a quarter of the 25,000 certified, but the growth is straight up. I mean, we have the most applications this year that we've ever had in the past, and it's over 2,000 of applications in 2019, and the inquiries. So I think at least for the short term, I see nothing but growth, especially with the new specialty areas coming on board in oncology. Women's health is relatively new, and then the wound management group. We'll see how that goes. So there is still a tremendous interest in this clinical specialization. About 20%. I'm trying to remember are residency people, but the rest are not residencies.
Interesting. Are they more like newer clinicians, or are you still are a lot of people still renewing as well? Because I know that's something I hear from a lot of clinicians that have had it. They're kind of like, I'm kind of going to let it expire because of the money and all this. And I'm just trying to be honest. That's what I hear.
Yeah, sure. And I wish I had the numbers in front of me, but the applications are still across the board at different age groups, although the majority is younger. But if you're doing it without a residency, you've got 3 to 5 years experience going. So you've been around for a while. And like I said, it's been 15 to 18% in residencies. The renewal has been very strong. And now we're going to the new system. The MOS system has already started in place. Instead of getting renewed every 10 years, it's every 3-year obligation. So, I mean, with honest, I just renewed for the 3rd time. I am good until I'm 77 years old, really hoping that I'm really thinking of backing it off around 75 and going to part-time, but we'll see.
No, it makes sense. I mean, it's totally understandable because because I've talked with a few therapists and I get it. Like, I understand how they may not want to pay all that to keep it up when, I get it. I mean, it's it's hard, and I don't know a right answer for that.
And I think the new system is going to be actually easier because you don't have this big bolus of work to do at the 7-year mark, but you do have something you have to do every 3 years, but it's all pretty well put together once you get all the glitches worked out on so you can put in your data pretty quickly, and it's also a way to stay current, so you don't go 7 years and not do anything. The whole idea is to continue competency. So hopefully it'll keep going. But right now, the renewals have been real strong. I don't know the exact percentage, and so I don't want to fudge on that.
No, that's really appreciated because that's just something I hear a lot, and I just had to bring that up.
Sure.
Well, Bob, I really appreciate your time and insight and your service with all that you've done. And thank you for, all that you've done. Thank you so much for coming on this evening and spending the time to chat with us. It's been a great pleasure.
All right. My pleasure too. Thanks so much. Appreciate it, all of you. Thanks very much for asking me.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.